الرحمن الرحيم. My talk today is malignant skin lesions. Malignant skin tumors. Prof. Mostafa El-Sonbaty, Assiut University, Egypt. Skin cancer is the most common cancer in human. It accounts for 1% of all cancer deaths. All cutaneous malignancies, including melanoma, have an excellent prognosis if treated early. Basal and squamous cell cancers are easily detected clinically and are often cured by excision. This does not mean that skin cancers are unimportant or should be neglected. When neglected, they may be deforming or fatal. This is carcinoma in the skin, showing the epidermis and dermis. The importance of this cross-section that the epidermis give rise to the three main skin tumors: basal cell carcinoma arising from the basal cell layer, squamous cell carcinoma arising from the brachial cell layer, and melanoma arising from the melanocytes scattered along the basal cell layers. Pre-malignant skin lesion is very important to diagnose these lesions early because most of these pre-malignant skin lesions can be considered as non-invasive or pre-invasive stage of cancer or carcinoma inside. Pre-malignant skin lesions or pre-cancerous skin lesions include actinic keratosis, or solar keratosis or senile keratosis is the most common pre-malignant lesions. Here, this is a picture for an elderly man with solar keratosis, dryness of the skin, pigmentation, and on top of this solar keratosis, multiple skin lesions developed in the cheek, in the lower eyelid, in the area of the nose. More recently, as regards the treatment, there is no treatment, but we can follow these cases, and if there is any malignant lesion, it can be treated. But some can consider the use of 5-fluorouracil, 1 to 5%, under the name of Efodex. This is not present. Second is Bowen's disease. Bowen's disease is seen in the older patient in both sun-exposed and non-sun-exposed areas. Bowen's disease is not present in Egypt. The same Bowen's disease in the external genitalia, especially the glans penis, is called erythroplasia of Gerard. And this is more important than Bowen's disease. But this is common in the uncircumcised men. But here in Egypt also there is no erythroplasia of Gerard. Treatment is conservative surgery. Erythroplasia is much more likely than Bowen's disease to become invasive and carries with it an increased tendency to metastatic disease. Leukoplakia. Leuko means white plakia patch, so leukoplakia is white patch. It's seen primarily on oral, vulval, vaginal mucosa. Leukoplakia in the mouth is seen mostly in older men with a history of smoking or ill-fitting dentures. Treatment for leukoplakia is lip shave, excision of this superficial lesion, and advancement of the mucosa of the inner side of the cheek to cover the excised area. Keratoacanthoma. Keratoacanthoma is considered as a self-healing squamous cell carcinoma. It is usually solitary and seen mostly in sun-exposed sites. The importance of keratoacanthoma is that it is difficult to be differentiated from squamous cell carcinoma even under the microscope. But For me, keratocarcinoma must be considered from the start as squamous cell carcinoma and must be treated as early as possible by surgical excision with safety margin. This is picture for keratocarcinoma, dome-shaped, with central keratinous plug. It grows rapidly over 6-week period and slowly regress over 2 to 6 months. But for this lesion, I advise early excision and not waiting for regression. Radiation dermatitis or post-radiation keratosis. This is very important. Precancerous skin lesion developed after the use of ultraviolet rays 50 years ago for treatment of many of dermatological diseases like alopecia and hirsutism. In these patients, chronic radiation dermatitis may develop followed by the appearance of either basal cell carcinoma or squamous cell carcinoma. When malignancy cannot be proved, excision and resurfacing is considered. Here, this is a picture for a patient with multiple basal carcinoma developed on top of post-radiation keratosis. In this patient, I detect up to 12 basal cell carcinoma. Here's a posterior aspect of the head. There is pigmented basal cell carcinoma multiple. This one and here. Lastly, xeroderma pigmentosum. Xeroderma pigmentosum, zero means dry, derma skin, pigmentosa pigmented. Xeroderma pigmentosa is a relatively rare systemic disease transmitted through an incomplete 6-linked recessive gene. As this picture shows the dryness of the skin and pigmentation with a small basal cell carcinoma in this area. And here the importance of xeroderma. Some classified precancerous skin lesion in 1978 broken into obligatory precancerous skin lesion and facultative precancerous skin lesion. The obligatory precancerous skin lesion include only one condition, which is the xeroderma pigmentosum. So xeroderma pigmentosum is obligatory precancerous. As regards the facultative precancerous, subdivided into facultative with high probability to malignant transformation. This includes only one condition, which is the post-radiation keratosis. And the remaining precancerous lesions lies under the facultative precancerous skin lesion with low probability for malignant degeneration. This picture for a patient with the xeroderma pigmentosum. The disease is characterized by severe sensitivity to sunlight, abnormal sensitivity to sunlight. Theoretically, if we can protect this patient from sunlight, we can delay the development of malignant genes. The primary deficiency is that the enzyme in the nucleus, which is needed to repair sunlight-damaged DNA. After exposing this patient, exposure to sun rays led to mutations, and these mutations normally removed by the endonuclease enzyme. But in this patient, have deficiency in this enzyme, and so accumulation of the mutant cells result in malignant transformation. Malignant degeneration into basal cell carcinoma, squamous cell carcinoma, and even malignant melanoma is noted during the childhood, with this due to metastatic disease. Usually the lifespan of this patient maximum during the second decade of life. Prolongation of life is possible by absolute protection from sun exposure and continual aggressive treatment of all developing tumors. This patient Here, just I want to show the cover of the body by the normal closes protect the covered area in comparison with the exposed area, the face, the neck, the back of the hands. Another case, the same protection by closes of the covered area. Now we shift to the main skin malignancies, basal cell carcinoma, squamous cell carcinoma, and malignant melanoma. As regards the basal cell carcinoma, is the most common malignant lesion, about from 70 to 75 of this lesion. Its occurrence is directly related to sun exposure. This common cause is exposure to irradiation. It is locally aggressive tumor that never metastasizes to some extent. There is some reports, but simply can consider the basal cell carcinoma locally malignant. There is no metastasis. It usually presents on the face above the line extend from the angle of the mouth to the preole of the mid-third of the face. Clinically, it starts as papule, plaque, nodule, and with time ulcerate with the classical ulcer of basal cell carcinoma. The edge is raised and inverted. These lesions are common on the eyelid and inner cancers where a high concentration of biosebaceous follicles exist. Clinically, we have many types of basal cell carcinoma. By far the most common is the nodular ulcer type, which is considered rodent ulcer. Second, superficial basal cell types, fire-filled type, morpho-like basal cell carcinoma, pigmented basal cell carcinoma. The second most important is the pigmented basal cell carcinoma, similar to the nodular ulcerative type. The lesion demonstrates deep brownish black pigmentation. I will show a picture. Histologically, basal cell carcinoma, the lesion demonstrates tumor cell arranged to form nests, cords, and islands within the dermis with a diagnostic palisade pattern. Palisade pattern means the lesion is surrounded with low columnar epithelium like a palisade. This is some of the cases when we look for this patient, look for the sex, for the age of the lesion, for the site of the lesion, for the character of the lesion. Here, basal cell carcinoma in patient with albinism, female patient in the mid-third of the face, tumoral region, with typical beaded edge. There is no ulceration, but this is the beads. Here, pigmented basal cell carcinoma, and also in the mid-third of the face in a female patient. Multiple basal cell carcinoma in male patient. This one is labial and this tip and another one here. Superficial basal cell carcinoma, to some extent like tinea, and this one of the differential diagnosis of the tinea. Also, differential diagnosis, eczema, psoriasis, Bowens disease for the superficial basal cell carcinoma. Fire-filled, this female patient with lesion in the midthird of the face. Here, when we look to this lesion, we saw very active periphery with sterile feeling here. This simulates fire-filled, so it is called the fire-filled basal cell carcinoma, more aggressive basal cell carcinoma. As regards the diagnosis, most of this lesion diagnosed clinically, but we can confirm this diagnosis by incision or excision biopsy. Treatment. As regards the treatment, either surgical, there are many lines of treatment, but here I will concentrate only on two types. Either surgical eradication or radiotherapy destruction. Surgical excision, the lesion, if we excise the lesion with safe margin at least 0.5 centimeter, both in width and in depth, followed by surgical reconstruction of the surgical defect. Radiotherapy, Here, radiotherapy, we use 5,000 rods, 1,000 per week, as an alternative to surgery. It should be remembered that scars from surgery generally improve with time, whereas those from radiation therapy worsen with time. This patient demonstration with cell carcinoma, margin for the septum margin, and the local flap to cover the defect. Here's the defect after excision. After moving the skin flap to cover the defect and closure of the donor site by simple closure, and after this, ask the patient to open her eyes and look for there is no ectropy in the lower eyelid, and this is the immediate result after excision under local anesthesia. The same patient before surgery, after removal of the stitches, there is no ectropion. Another case, basal cell carcinoma dorsum of the nose, destruct most of the nose in elderly female. For this patient, the excision with septum margin down to the bone and the cartilage because not involved, and use midline for head flap from this area to cover the defect. Look for this tattoo moved from the forehead to the nose because this is the site of the flap. This is one stage repair using midline for head flap. Excellent result. Second, squamous cell carcinoma. Squamous cell carcinoma is the second most common skin tumor after basal cell carcinoma. From 20 to 23% of skin cancer. Also, it is related to sun exposure and exposure to irradiation. Also, it occurs in elderly patients clinically, start as a plaque, nodule, or ulcer, and here the ulcer is characterized by raised inverted edge with indurated base. Also may develop as a marginal ulcer. Marginal ulcer is spontaneous ulceration on top of all standing scars. Scars for 15, 20 or more years may ulcerate spontaneously, give rise to marginal ulcer. Histologically, here the lesion reveals atypical squamous cells that are well differentiated with development of epithelial peels, concentric layers of squamous cells with central keratinization. This is for differentiated lesion, but central keratinization not appear in the cases with undifferentiated lesion. Squamous cell carcinoma can metastasize locally. In addition to local split, can metastasize locally by the lymphatic and by the blood split. Very, very rare to get blood split and very late, but usually may spread by lymphatic split. Treatment, same like basal cell carcinoma with difference in the safety margin. Either surgical excision or radiation therapy. As regards surgical excision, excision with septum margin at least 1 centimeter septum margin, both in width and in depth, followed by reconstruction of the surgical defect. Reconstruction using skin graft, simple closure, local flaps, any lines of reconstruction. Radiotherapy, the same, 5,000 rods, 1,000 per week. Some cases, squamous cell carcinoma lower leg, and here in the neck there is enlarged cervical lymph node. Another case, advanced case of squamous cell carcinoma lower leg. Also squamous cell carcinoma lower leg in patient with albinism. Squamous cell carcinoma in the auricle. The third common site is the scalp cauliflower squamous cell carcinoma with enlarged occipital and post-auricular lymph nodes. Marginal ulcer, ulcer is spontaneous ulceration on top of burn in the leg. This is the knee, and this is burn, and down is the foot, and this is the marginal ulcer. Another case, marginal ulcer on top of systemic lobus vulgaris, TB of the skin, and this lesion was found to be superficial, so excision with skin graft succeeded to treat this case. Otherwise, if the lesion infiltrates the underlying bone, we will amputate the arm. But here, this lesion was superficial, and this is the result after excision and skin graft. Fungating squamous cell carcinoma cheek, and this is the result after excision with the use of folate flap to cover the defect. This is the skin graft in the donor side, and this is the part of the flap used to cover the defect after excision of the lesion. Another case, squamous cell carcinoma lower lip, excision septum margin with local flap fan shaped. This is the result 5 years after. Another case, squamous cell carcinoma lower lip, excision through and through in a picture of W. Then this defect closed by sharing the upper lip in reconstructing the lower lip by a B flap. This is a B flap. This will be shifted down to help in closure of this defect. Result 5 years after, excellent result. 5 years, no scars, can be considered excellent result without any recurrence up to 5 years. For reconstruction, some difficulties, so this is a silicone to replace the excised part auricle periocular holes nodes. Lastly, malignant melanoma. Malignant melanoma or melanoma or malignant, there is no benign melanoma. So some consider the title melanoma only, or some consider malignant melanoma. Malignant melanoma, neoplasm of neural crest-derived cells that have differentiated to melanocyte that lie in the basal cell layer of the epidermis. Sometimes it is lethal. Cutaneous tumor, it was account for 1% of all cases from cancer. Early detection and improved diagnostic accuracy were associated with improved 5-year survival rate. It is usually common in fair-skinned individuals who are exposed to equatorial sunlight. Also uncommon in blacks, it may occur in blacks in sublingual and plantar aspects of the hands and feet, respectively. Also, the primary growth may remain small, rapid spread to lymph nodes, and widespread hematogenous dissemination may occur at an early stage. Also, recorded transplacental dissemination to the fetus. Clinical types of melanoma, there are lentigo-malignant melanoma, not present in Egypt, superficial splenic melanoma, common in the legs in females and the trunk of males, but for me, all my cases lies in the legs, and especially in the foot, and more specifically in the transition between the plantar and dorsal surface of the foot. Histological examination. Here we can see collection of malignant melanocyte in the layers of the epidermis, and according to the extent we can give the level or the thickness of the lesion. Nodular melanoma, the most aggressive form, the most common is superficial spreading, and most aggressive is the nodular melanoma because it spread vertically with increase in thickness, which is very important as a prognostic factor. Lastly, acral indigenous melanoma, the same. Nodular melanoma in the sublingual region in the blacks. Histologically, the large atypical melanocyte develop within attacking the epidermis and spread rapidly along the dermo-epidermal junction. Although most melanomas arise de novo, 90%, some may commence with malignant change in junction nevus that persist after puberty, 10%. For me, all my cases de novo. Repeated trauma for nevi can give rise to malignant transformation. All cellular nevi, pigmented nevi, exposed to friction or trauma, should be excised or fractured with septum margin 2 mm and histological assessment to exclude malignant transformation. Some pictures, this case of superficial spreading melanoma. This is the main lesion, and this pigmented lesion around is called satellites with hollow depigmented region around. This is also the site and junction between the plantar surface and the dorsum. This is the basal, in my mind, this is a basalnomic site for malignant melanoma. Nodular melanoma, also the same site, junction area between the plantar and dorsum. This is nodular melanoma, about irregular outline, 2 cm by 1.5 cm, but raised above the skin by 5 mm or more, so the prognosis is very bad for this patient. For this patient, the excision with skin graft was done with septum margin about 5 cm, but this is the follow-up after 1.5 years with excellent hyperkeratotic skin grafted area, no elephantiasis in the food. The patient was obese, but this patient has no inguinal lymph node palpable till now, but multiple abdominal swelling with cannon metastasis in the chest. So from the start, I consider this case as a bad prognostic case. Nodular melanoma in the subingual region, which is called Indigenous or nodular melanoma. For this patient, excision of only just excision of the big toe, but this is too late and very bad prognosis. Another case, nodular melanoma in the same area, junctional area, with skin with shiny appearance that is pathognomonic for melanoma. Prognosis: in the absence of lymph nodes involvement of the hematogenous dissemination, prognosis is determined by the histological extent of the invasion. So, if there is no palpable lymph node, all investigation exclude metastasis, so the thickness of the lesion is the main factor for assessment of the prognosis. We have, according to the Clark level of invasion, 5 levels. Level 1, intraepidermal cells superficial to the basement membrane, this one. Level 2, the reach to the junction between the papillary, or reach to the papillary junction between the papilla and the reticular. Level 3, papillary reticular. Level 4, to the tips of the reticular region. Level 5, outside the skin proper, reach the subcutaneous tissue. Correlation: the superficial benign melanoma is usually composed of level 1 and 2. Nodular invasive type is usually 3 to 5, level 3 or level 5 to level 5. Associated ulceration is indicative of poor prognosis. So, bad prognosis, thickness of the lesion, the depth, and the ulceration. The more deeply penetrating lesions have a greater prospect of regional lymph node metastasis and a poor prognosis. 5 years survival rate by Clark level of invasion, level 3, 70%, level 4, 55%, and level 5, 20%. Breslow classification. Breslow consider oculomicrometer assessment of the thickness of the lesion. The depths of penetration correlate with the overall survival. So, according to the Breslow, melanoma less than 0.75 mm thickness has good prognosis. Melanoma penetrate from 0.76 to 1.5 mm thickness, increasing metastatic potential up to 30%. Melanoma greater than 1.5 millimeter thickness, highest incidence of regional lymph node involvement with poor prognosis. As regards the lymph node, status of the relative to 5 years survival rate. If no regional lymph node metastasis, good prognosis, 75%, 5 years. 4 or more, 25%, 5 years survival rate. Lastly, management of the malignant melanoma. Careful examination of the lesion and the regional lymph node is essential. Lymph node enlargement may be developed after previous excision of a pigmented lesion with no evidence of residual melanoma under the well-healed scar. Investigation to exclude malignancy or metastasis. Treatment for the early lesion and treatment for advanced lesion. As regards the early lesion, there is no lines of treatment other than surgical excision. Once a histologic diagnosis of melanoma has been made, a wide local excision is carried out so that no residual melanoma cells are left. Now, in the past, the septum margin was 5 centimeter septum margin at least, but now we according to the thickness of the lesion. Thickness less than 1 millimeter thickness, 1 centimeter septum margin is sufficient. But if the thickness is more than 1 millimeter, the septum margin will be 2.5 to 3 centimeter, down to the deep fascia. No need to excise the deep fascia because the deep fascia acts as a barrier to continue lymphatic spread. Excision of deep fascia is not necessary. With the adequate removal of the primary lesion, the wound is closed by suture, if possible, or by either split-thickness graft or local filling. Regional lymph nodes, there is, if the regional lymph nodes are clinically involved, a radical lymphadenectomy should be done. A pathological involvement of one node reduces the prospect of 10 years survival rate. Involvement of 2 or more nodes reduces the survival prognostic. Here, demonstration patient with melanoma, also in the junctional area, and here there is lymph node in the inguinal region. The high controversy about the lymphadenectomy prophylactically in the absence of the apparent involvement. In general, if one takes into account the patient age, the state of general health, and the patient preference, it appears reasonable to recommend prophylactic lymphadenectomy when the lesion thickness is greater than 1.5 millimeter and in patient with Clark level 4. Lastly, treatment of disseminated melanoma. Tumor is radio-resistant, chemo-resistant, immunotherapy till now experimental. So, for surgical excision, if there is solitary lesion in the lung or in the brain, we can excise. For the as a palliative treatment for relieving obstruction in the intestine can be done, followed by radiotherapy or chemotherapy. Immunotherapy till now experimental using BCG. Chemotherapy, either monotherapy or multitherapy. Monotherapy, dacarbazine. Multitherapy combination include vincristine, bleomycin, lomotacine, and dacarbazine. The first give rise to recession by 25%, the combined by 40%. All these are palliative lines of treatment, and also radiotherapy. The tumor is radio-resistant, but we can try get 100 rats weekly. All are palliative treatment. Thank you very much.